Welcome, everybody, to the Interventional Endoscopist podcast. This is our interview series, and today I have a really special guest, a good friend of mine, Dr. Neil Sharma, who was previously the president of the Parkview Cancer Institute and the director of Interventional Endoscopy Oncology and Surgical Endoscopy Programs. They call that the IOSE. And he was also chair of the Upper GI Oncology Tumor Site team, as well as a program director of the Interventional Endoscopy Fellowship. So he was not busy whatsoever. And I didn't do anything. But I say formally because, Neil, I'd like to say hi, and you can tell everybody what you're up to now.
Hi. So first and foremost, thank you for having me on your podcast. I listened to the podcast and subscribe to it, and I would encourage everybody who's listening today to do so. I think there's a lot of unique things that you touch on in your podcast for a variety of perspectives that sometimes perhaps we overlook when we give academic lectures or other types of medical podcasts. So I love your unique perspective. So thanks for having me on. I think that's great, and I think everyone should be really listening to what you have to offer, because every time I've listened to your podcast, I've gotten something really unique, and sometimes it's relevant to day-to-day practice, or sometimes it gives me a new perspective on how I approach particular problems. So thank you for having me.
Oh, thanks. Thank you.
So you alluded, I made a recent move. I moved to Colorado. I'm here now, and we moved about 3.5 weeks back. I stepped down from my position at Indiana and moved over here. I grew up in Indiana, essentially. I was born in Chicago, and we moved when I was really young as my father got transferred. I enjoyed that role, and I still consider that place home. So I'm in a new land. There's a lot of mountains here. The skies are really clear, so I can't complain about that, but I'm still getting to know the lay of the land. I officially start here on February 1st. So I have a little bit of time on my hands, just a little bit of breathing room, stepping down from the prior roles and into something brand new.
Yeah, no, absolutely. And I think another thing that we can do is in 6 or 7 months, once you've completed this transition, we can, redo another podcast about like how it went and, all your thoughts of it at that point in time. So that's exciting. Change is always tough for us as physicians and also for our families and stuff. So it's going to be a fun time, I think. I think you can do great things up there. So to continue, Neil basically went to medical school at the Medical College of Virginia, did fellowship and a residency and fellowship at the University of South Florida, and then advanced endoscopy at the University of North Carolina at Chapel Hill. We always have to say at the Chapel Hill because it's like Ohio State. You have to call it the Ohio State University. So, and I chose to interview Neil for several reasons. Number one, I think anybody watching this podcast knows who he is now. You've come a long way in the interventional world, and you're a leader at FIGHT, a co-founder of it, and that's kind of how I met you as well. I think it was DDW at San Diego. It was at a rooftop bar where everybody was having way too good of a time, and we were talking about some controversies in interventional endoscopy and training, and that kind of led to us creating this relationship. And then he co-founded FIGHT with Sharma and some of the other guys, David Deal and those guys. And that's been taken off. And then also he's a leader in a kind of a new field in interventional endoscopy, which we touched upon briefly on one of the earlier interviews I did with Tufik Kachami, where we talked about endoscopic oncology. And I think that's going to be one of the focuses of our conversation today. But, that was the main reason when we were talking, outside of, the commonality of interventional endoscopy. This is a new field that I think you're pioneering, and it really, it's something exciting that we got to talk about a little bit more. But before we get into that, just a little, you mentioned a little bit about your background, how, you grew up in Indiana, and your father and mother moved there when you were a child. But what about, kind of talk about how you became a physician? What were your influences, and all that sort of stuff, and what kind of got you to being a doctor when you were a kid? Other than the fact that all Indian kids are told when they're from the womb that they're going to be doctors. So.
I think that's probably number one, to be 100% honest. Right? So parents are immigrant parents, and that was a big thing. Like all Indian kids probably growing up here, at least in the United States, that's like the number one thing. Like you're going to go off and do well in school, and then we'd like you to be a physician. I was lucky, that I had parents that were there and told me to do that kind of work and emphasize the importance of education, to be honest with you. I think I was a bit more of a free spirit. I like to think freely and try to be innovative even today, to this day. despite being within the constructs of a particular field, such as medicine, that requires a certain amount of organization and discipline. But I was a bit more of a free spirit. My younger sister Neha is a radiation oncologist, and I think she was much more organized and hit all of the milestones the way that exactly it should be done. I definitely did really well in school, and I had that opportunity simply because of my parents emphasizing education. So I did the same thing. But I was a history major actually in undergraduate. I chose to kind of go a different route in undergraduate right before going into med school. So I still did kind of the old traditional route through medical school, 3-4 years of undergraduate, and then move forward. But during that time, I had the opportunity to focus on some of my other things that interest me, which include reading, literature, writing. I think I had the opportunity to do some public speaking and things like that at that time that I enjoyed doing, and thinking outside the box a little bit because the liberal arts are just a different mindset. But lo and behold, as with most Indian kids' paths, I followed what my parents had asked for and went down the medicine path. But it was great. Honestly, for me, going from being a history major with a minor in English and philosophy and having no multiple choice tests to jumping back into medical school right away, with no real gap. What I found was what was most interesting was just the relationship with people. And, when you go into third year, you kind of see suffering for the first time, right? You are usually relatively rather young in your life. And what you're jumping into is seeing people in a time of need. And that really woke me up, to be honest with you. Like that was a big thing. And then I enjoyed working with my hands. So I kind of found the right space to deal with both of those items. And here we are.
Yeah, absolutely. I mean, it's a common thing. And, my daughter's a senior in high school and she wants to go into medicine, but I hope that for her pre-med study, she does something that really interests her. Like I if biochemistry is what it is, that's great. But if she likes history or likes English literature, music or something, I hope she studies those things, because I do feel like it helps broaden your horizons later in your life. And so yeah, it's a really good thing. I'm glad. I mean, that's a little bit off the beaten path for most of us.
Yeah, so it's pretty different.
Yeah, that's awesome. So why GI though? Why medicine and why GI? Other than, you like to work with your hands, but what can you think of a mentor or somebody who influenced you during residency or med school that kind of pushed you in that direction?
Yeah, in medical school, you have to try to make decisions early. And sometimes, unless you have a really strong exposure to medicine, you're not really sure what you're jumping into, to be honest with you, right? So you kind of go with what you hear and know. I think I had a close family friend and a cousin. They're both ENTs. So I thought I was going to do ENT and started working on the early match. I did a lot of my electives second year, kind of focusing on that. Mm-hmm. And then as I was going through third year, I had medicine actually at the end. And I found that people were asking me questions all the way up to kind of that medicine rotation. And I couldn't answer any of them. Like those simple questions, as many of my friends who went from undergraduate were not in medicine, I just couldn't answer them. I mean, I knew the ENT questions really, really well. I kind of knew that world, but that was a really finite world. And then when I did the medicine rotation, it was like, wow, this is like what I thought in my mind, not being exposed to what medicine could be like or what it should be. And I was like, I think this is probably the right route. I can still find a way to work with my hands in some other field within medicine. But I think doing that core of internal medicine would make me feel like I'm well-rounded. I can answer some basic questions around medical health that was asked of me on a regular basis. So I went down that route. And then that kind of leaves you with two things: interventional cardiology or GI, really, if you're going to get yourself into a lot of procedures. Perhaps pulmonary critical care would be a third option, really. Right. And so, when I went down that route, I thought, just like everybody else, I'd just do interventional cardiology because I just didn't have the GI exposure. And I was more interested maybe in oncology, but that was more back again with the ENT background because there was a lot of head and neck cancer exposure when I was doing that research. And then I found as I did a GI rotation, there's a GI doctor named Matt McKinley. He's done a lot of Barrett's publications. He's out of New York and Long Island. And his son, Joe McKinley, was my senior when I was an intern in medicine. And he was like, hey, you really should consider doing GI. And I was like, well, I don't know much about GI. I don't really have an interest in that. I'm thinking to do interventional cardiology. And he started talking about, well, if you have an interest in cancer, there's an opportunity with interventional endoscopy to do that. And, it was something I had no idea about. And as I did some rotations at Moffitt Cancer Center, which was part of USF, right, I got exposure to people like Jason Klattman. Who really kind of opened my eyes up that there is a field out there. There's an opportunity to deal with cancer, be highly involved in hands-on work, and kind of meld oncology as well as just the physical aspects of endoscopy together. So that's where we're at.
And the seeds were planted in intern here. That's awesome. So speaking about oncology, then let's get into that because I think that's going to be the bulk of what we talk about today is endoscopic oncology. So maybe just briefly for the audience, like, this is a term that you're hearing more and more of on social media, a lot because of some of your postings and things like that, and some of what Tafiq's posting. But a lot of people don't, you're an endoscopist and an oncologist. So can I maybe explain what is this field and what outside of what you just talked about, is there any other reason you got into it?
Yeah. So, I mean, I had a natural interest in oncology going all the way back to even those ENT times, all the way back to medical school. But, I think when we get involved with interventional endoscopy, if you think about the bulk of the work that we do, a significant portion of it does intersect with the oncology realm, right? So think about it. Endoscopic ultrasound was invented, maybe in the 1990s with the precipice that we can take a look at hollow organs with higher detail and start to do cancer staging. That's really what it was made for originally, like radial diagnostics, and then it advanced. A lot of that work actually was done originally by the IU group with individuals like Rob Hawes and Frank Gress and so on and so forth. And so they really built up this focus, but it was started out with oncology. If you think about a bunch of the interventions, whether that's ablations, they're either for precancerous lesions like Barrett's, which was a major exposure for myself and a big interest to do work at UNC with stars like Nick Shaheen. It was oncologically focused, and trying to prevent downstream cancers. When we look at things like cholangioskopy, yes, it can be used for breaking up big stones, but it can also be used to stage cholangiocarcinoma, and then we can do ERCP with RFA. So if you start to look at the totality of our work, ESD is another big focus of mine, as you know, and ESD, I primarily use it not for adenomas. To be honest with you, I predominantly use it for esophageal and gastric cancers, early neuroendocrine tumors of the rectum, that kind of work. There are times where there's high-grade dysplasia adenomas that I will resect with ESD simply because of size to get an en-bloc resection. But ESD was really a cancer-based surgery that came out of Japan. So if you look at that work, there's definitely a big focus of benign pancreatic biliary work, chronic panc, and so on that comes out of doing an interventional fellowship. But if you look, most of the work that's out of EUS, enteral stenting, which usually is for malignancy, right? ESD work, and then like the ablative work that's really coming down the pipeline, a lot of that's cancer-related work. So it seems like a natural predisposition for us to work in a realm side by side with medical and surgical and radiation oncologists. And so that's really the precipice of getting interested in oncology, bringing oncology into the endoscopy realm and letting us work synergistically.
Yeah, absolutely. And so, I mean, how do you see this field kind of growing into the future? I mean, right now there's just a handful of guys that most of us can name who are, I wouldn't say calling yourselves endoscopic oncologists, but, you're affiliated with that world. And so when we think of that, we think of, Sharma, Tafiq. I think we think of, I'm blank on his name, but a couple other guys around the country,
Brian Eagle does a lot of that work. I think he wrote a book called Endoscopic Oncology, actually, didn't he?
Who was that?
Brian Fagel, I think.
Yeah, absolutely, yeah. And he was at Oregon, I think, if I'm not mistaken. Back, no, not Doug. No, Doug Fagel. He's out at Mayo. Yeah, he was a chairman.
We Howard to mention him on this, so
Yeah, he was definitely, actually, that's right, because he did have that textbook out in early 2000s sometime, and yeah, good guy, actually. He's still practicing there. So, but I mean, who are in some, like, who should be getting into this? Should it be all interventional endoscopists? I mean, is this something that, you do your interventional endoscopy training? Should you do extra training in endoscopic oncology, specifically in the tissue resection? Because I know we all touch the subject, as you mentioned. We're all going to be, we're all doing EMR. We're all learning or trying to learn ESD as a community. We're all doing stents. We're all doing everything you mentioned. So is this something that should be a separate field in interventional endoscopy, or should we all be kind of participating in that?
Yeah, that's a great point. I think when you ask that question, it's very intuitive because, the question is, it doesn't need to be a separate field, or should it be integrated into the totality of a complete interventional endoscopy program? And I think it should be the latter. I mean, I think we should all be participating in it. And I'll back up and just kind of take like 100,000-mile up view of totality of medicine, right? So if you look at medicine as a whole, the number one cause of death has always been cardiovascular causes, right? But that's changing, and probably they predict by at least 2050 will definitely be cancer as the number one cause of death. more people will be living with cancer and dying from cancer than anything else. It'll be the biggest portion of the gross domestic product. I mean, just even recently, if you look at like cancer statistics on SEER database, it's almost 2 million new cancer cases in just 2023 alone, right? And then 609,000 deaths. The 5-year survival rate has definitely improved, and a lot of that has been the advent of immunotherapy due to the new boom in medical oncology, as well as targeted therapies, improvements in minimally invasive approaches to surgical resection, and better outcomes for more morbid surgeries. But that boom in immunotherapy and targeted therapies will only continue to increase. So more people will continue to live with cancer. So if you look at like the 5-year survival rate, which used to be around 49% 5-year survival rate in the mid 1970s, and you start to look now at like 2012 to 2018, the SEER database says it's around maybe 68%.
Yeah.
But people are living with the cancer. So that means there's more palliations for us to perform. There's more opportunities for us to get involved in this space. Additionally, cancer accounted for about 18% of the 3.3 million recorded deaths in 2020. So that's like a significant portion of deaths, right? And we know that more people will be getting cancer because they're living longer, they're surviving cardiovascular disease. We have better medicines. So even before you go see the interventional cardiologist, you may be on statins, blood pressure lowering medicines, and might be at the point where less of that type of intervention is needed for cardiovascular purposes. So if you think of the whole thing as medicine as a whole, cancer will be increasing in total numbers. Cancer will be increasing in people dying from it, and the opportunity to help people living with it and living longer will all increase. And as I mentioned previously, a lot of our interventions are related back to cancer. Right. Even some of the hot topics. So let's just think through some of the hot topics. EUSGJ, for example, that's typically done in malignant cases. I mean, it can be done in benign cases. In fact, we have a trial we're working on that now, but it's a very, very low proportion of that, right? ESD, as you mentioned, a lot of that's cancer movement. And even if you don't do ESD and you're focused on the core of interventional work, pancreatic or biliary, likely a good portion of your US is related to looking for cancer, looking for precancerous changes, staging cancer, perhaps you're ablating cancer, and so on. So I think it's important for us to do it. Maybe another question to ask is, how do we do it? How do we incorporate that in a program?
Yeah, absolutely. How do you do it? And if you're going to create a program, how do you start one? So what's your advice? You've done it twice and now you're doing it a second time. So what's your perspective?
Yeah, I think we have to start to speak the language of oncologists. So, if you and I were to go take a road trip and we're going to go down to Latin America or we're to go to Japan, it would really help us if we could speak the native tongue in order to be able to communicate effectively and collaborate with individuals in their native state. And that's how I look at oncology. Oncology has become much more complex. It requires really strong workups through multidisciplinary formats to be able to get the optimal outcome for their patients. So the old cancer model would be treatment focused, right? So you think of oncologists treating cancer. Actually, the forward-thinking model now, one that's really sustainable, that these larger systems, especially those ones that are per capitation, such as Kaiser and these bigger health systems that are thinking about how we can actually save lives in the cancer world, are forward thinking. They're looking at early detection and prevention of cancer, which is actually the best way to treat cancer. It's the most cost-effective way, the least morbidity. It looks at diagnosis and getting the diagnosis staging right, because we know that certain aspects, if you put neoadjuvant therapies first, you'll have lower recurrence rates and better outcomes. And of course, treatment, which we mentioned as a cornerstone. And then finally, survivorship. So if you think about those different paradigms, like early detection and prevention, we're 100% involved in that aspect.
Absolutely.
Yeah. Like pancreatic cancer screening programs would be a great thing that I would recommend every interventional program to have.
Right.
And that requires working very closely with your local cancer institute, or if you're in, don't have a major cancer institute nearby, that you still can be highly involved because you just work with the oncology groups that are in your region and you set up a cancer prevention program. And it can be pancreas to begin with, but definitely things like Lynch syndrome and so on need other types of screenings as well. You don't have to be an interventionalist to be involved with that, right?
Absolutely.
So that's a big one. And then diagnosis and staging would be imperative. And we can get into this a little bit later, but understanding the language of oncology means understanding AJCC guidelines, understanding NCCN guidelines. And once you know AJCC guidelines, you start to incorporate those into your reports when you do a thing like an EUS or even a straightforward upper endoscopy for an esophageal cancer. Knowing a Seaworth score is super, super important. So I would recommend, thinking about cancer, speaking cancer nomenclature, which comes to understanding AJCC and NCCN, going to tumor boards. I think it's a cornerstone of an endoscopic oncology program.
Right.
And remember that even if you're not directly most motivated by endoscopic oncology, by getting involved in these states, the total volume of your interventional work as a whole, stents, EUS, ERCP, and endoluminal therapies, will significantly increase. So those others in your group who perhaps want to focus on chronic pancreatitis or benign biliary interventions, they're going to have their own work. You're going to have your own work. You're going to be working symbiotically, crossing over on call, crossing over in coverage, but you're going to grow the totality of the program.
Absolutely. No, and I think one thing I really like what you said, you and I have both been involved in the ASGE fourth year fellow program as program directors and, kind of on those committee meetings. And there's been a push for standardization on some of the things in training. And one of the weaknesses our program had is lack of tumor boards, because we're at a community hospital that wasn't affiliated with a cancer center. And, you get busy and it's like, okay, who's going to go and set up a tumor board or work in one? But I think that's key, especially if you're going to be in the world of endoscopic oncology. You need to go to those tumor boards. If for nothing else, other than understanding and learning about the patients, you'll get business just by showing your face up there, But the thing is, you need to be in those tumor boards because you can then understand how you fit into the world of, diagnosis and treatment and that sort of thing. Also, a lot of oncologists don't really know what we can do. There's still people sending patients for whatever biopsies percutaneously, and because they just don't realize that maybe their community has EUS or they don't realize what's available to them. So I think that's a key thing is the tumor board thing. If you want to get started in endoscopic oncology and you want to maybe grow a program, you need to get out there and meet people and be in the tumor boards and learn their language, as you said, and also be part of it, be part of the process and, work with them to set it up.
Yeah, you hit the nail on the head, right? I mean, all of us would rather be in the endoscopy suite doing complex procedures than to be at another meeting or a tumor board. I mean, I get it. I totally understand. While I find it intellectually interesting, I don't imagine that everybody would necessarily, but it pays dividends, right? If you go to an upper GI or a total GI tumor board, you're going to see IRs always present. So that's how that field built up. We went from biopsies to doing things like Y90 and ablative therapies, percutaneous RFA, percutaneous cryo, because they were in the space and they were involved in the conversation. So you definitely hit the nail on the head. I'm part of that ASGE. I'm the vice chair of the ASGE's special interest group for endoscopic oncology. We started this year, and it goes along exactly what you said with the fourth year's fellows item is we have to recognize that this space is important. And when we want new technologies to come, so for example, EUS RFA, people will ask me sometimes, hey, I saw that you published on ablation of insulinomas, or you're doing EUS RFA, you're doing cholangioscopy, and then doing ablative therapies for cholangiocarcinoma. How do you build that up? It starts 5 steps back by just going to tumor board,
right?
Getting those biopsies. How do you put fiducials in? Well, if you're not having conversations every week with the radiation oncologist, it's unlikely that you'll understand their needs to be able to fit them.
Absolutely, and that's that's as simple as being at a tumor board, even picking up the phone and calling them and saying, "I'm seeing this patient. They're going to come to you. Do you want fiducials?" and more often than not, the answer is, "Yeah, just put them in because we could always use them if we need them down the road." And it grows that business big time. But when you were starting the program back at Indiana, what were like some of the challenges and pitfalls that you kind of experienced setting up this endoscopic oncology group and workflow and practice model?
Yeah, my mentors at UNC, Nick Sheens is a big part of that. Dr. Grimm, Dr. Gangarosa, the whole group, Dr. Barron's there now. I mean, it's just a great group. I think just like any good mentors, they wanted me to go to an established program first. And to be honest with you, that probably would have been what I had to do. But, I happened to go home because my parents were there. So then I was in a situation where I have a skill set. I really want to do something. So I got to create it from nothing. And that, happened to be at a not-for-profit, large health system that's now 12 hospitals. So it worked out in that sense that there was enough volume there to be able to do it. So I think you have to find an area that has some volume. But that's usually not that difficult because the reality is, this is a gap, and as you said, many people don't know what we do. So you can go anywhere there. I think the next step is, and this is like anything in the world. I don't think this is necessarily relevant to building a program, but it's relevant to anything you choose to do in life. I think you have to make a commitment that I'm going to do this thing, and I'm going to make it real. I'm going to make my concept in my mind a reality. And that involves just simple things. Like first and foremost, say you're going to have a program and coming up with a name. Like I think we should have a name and own it, because now you found a space, you want to create this space. The next step is let's make a name. So for us, our interventional oncology program started out being called an interventional endoscopy and endoscopic oncology program. That was the very beginning, the first name in like year one. As we evolved and we started to do more third space, and I did a lot of ESD and we're doing endoluminal therapies and ablations, we decided to do interventional oncology and surgical endoscopy. So we own those names. The reason why we own those names, if you think about what does surgical endoscopy mean to a patient, take all the medical jargon out. They think they're having a surgery if you're cutting something out of them, right? In EMR and ESD. So that was easy for us to explain to patients, and patients gravitated towards it. So it doesn't really matter on getting hung up what the name is, whether you choose to say your program is going to be endoscopic oncology, it's a subset of your interventional program. If you want to use interventional oncology, I think that's very reasonable. I know sometimes radiologists use that. All of that's fine, but I would pick one of those two names and I would incorporate and embed it into a comprehensive interventional endoscopy program. And then I would go to making connections. That's step 3. So step 1, make a determination and create the space. Just make it real. Number 2, own the name. Number 3, I would make the connection. So you talked about this, you hit the nail on the head. Be at tumor board, start to call people up. Every time you get a case referred for EUS, I think it's worthwhile calling in the first year or so the medical oncologist, radiation oncologist, surgical oncologist, and talk about the case, but then also say, hey, next time, maybe if the patient has a total duodenal obstruction, instead of doing a laparoscopic GJ, we can do an endoscopic ultrasound GJ so I can get them back on chemotherapy, or I can put a duodenal stent. Hey, I can actually do an ESD on this T1 cancer. I think it's important for them to know, so you start having these conversations.
Yeah, no, absolutely. Absolutely. And I think that's, if you have the support of your hospital system or your practice, to host small gatherings or dinners or, cocktail hours or whatever it is to talk about these things, you can grow it. And then obviously a lot of fellows probably don't realize this, but your industry reps are very motivated for you to use their devices and their products. And so, they can host something. Obviously, everyone has different feelings towards working with industry or, that sort of thing. But, that's a resource that a lot of people use and some people don't. It could be a benefit, so I think that's there as well.
I agree with you. I think any way in which you can make connections and create conversations is great. For us, being involved with a not-for-profit health system, they're willing to host some of those dinners that you're speaking of. That's great. But if you don't have that opportunity, that doesn't mean that you don't have opportunity. And certainly I can work with a device company, can still be agnostic. It doesn't have to be biased. They'll host it, but you can talk about whatever you need to talk about. And usually the best way is just talk about a disease state, because it goes back to your point, which is, another big key aspect is to leverage our skill sets as endoscopists. So set up a dinner. It could be sponsored by a device company, drug rep company, or it could be through your not-for-profit health system, whatever that may be. Right. But make it about a topic. Just make it about esophageal cancer or pancreas cancer. Invite everyone. So it's multidisciplinary. Right. But in that time, if it's about cholangiocarcinoma, talk about the role of cholangioscopy. Talk about RFA ablation and what that can do. Talk about complex stenting and how that can open things up. There's an opportunity there. And I think you're creating a conversation. The other big thing I think that's important, if you want to set up a program, is to be able to understand oncology from the medical, radiation, and surgical oncologist perspectives. And what I mean by that is, anytime that you want to relate to people, you need to understand how things look from their standpoint, from being inside their shoes, from looking at it from their lens, right? And if you know what their pressure points are, then you're able to help them and provide value, because that's how you can leverage our skill set. So for example, I was at Tumor Board here in Colorado and I haven't even started, and I was asked to come and Tumor Board the surgeon. Of course, I'm going to say yes. And then there's a couple of cases that popped up that they immediately wanted help with. One was a caudate lesion that was small. It probably could get radiation oncology SBRT, so CyberKnife directed therapy, but they needed a biopsy and they needed fiducials. IR can do it, but it's a little more complex for them. And I was able to say, hey, we can do this easily with the US, all in one setting, biopsy it, get the answer. If it's cancer, I'll drop fiducials in. Right. But I couldn't do that if I didn't know what they needed, right? Their perspective.
Yeah, absolutely. No, and another kind of point I wanted to get your take on, and Tafik and I talked about this briefly, but when we mentioned who, right? So tell me your thoughts on this. I have this belief that interventional endoscopy fellowship is going to change over the next 5 years. Right now you're seeing interest in different subspecialties. The biggest interest in that all the applicants are wanting to learn about is third space, right? Everyone's that's the hot topic today. But endobariatrics is coming up the pipeline as well. And now you have endoscopic oncology. Do you see a world in which our interventional fellows are maybe doing 6 months of general interventional endoscopy, where you're learning your ERCPs, your EUSs, and then you're like subspecializing in one of these branches that I mentioned, endoscopic oncology being one of them. And so in terms of who's doing that, is this going to be a world where all the trainees are getting exposed to everything, but then your last 6 months, year, 3, whatever it is, you're going to be focusing on a specific branch, advanced tissue resection versus third space versus oncology versus bariatrics? What do you kind of see happening in that world, and what's your take on that?
Yeah, that's really interesting. I think you're opening my mind up to a lot of potential possibilities, because it is nice to have a subspecialty or a niche focus, within a group. I know that when we were at 3-4 interventional endoscopists, all of us had a little bit of a focus on something. We all did EUS, ECP, colon EY. I think those are like the backbone of what we do in internal stenting. But we have at least like research or intellectual interests, perhaps like in something like an ESD. I was the one person, like many programs, 1 out of 4 or something, that have that focus, because that's related to oncology. So I think that's all possible. What would be really great is, I like to think freely, and I think you're opening my mind up, and I think we should be always open to the possibilities, because our field will keep changing. This is the beauty of interventional endoscopy. You can do things differently, and it might be opening up a whole new paradigm for us, which is great. It's creativity that we do every day. I think on the other side, the yang to that yang would be that the reality is we need comprehensive interventional programs. They should be able to do a little bit of everything, and I think it alludes back to what we talked about with ASGE. So what does a comprehensive program look like? It's kind of like a comprehensive GI program. You have IBD people, you have hepatologists, you have people who do motility, you have people who do interventions, you have people who do general core work. And same thing. Eventually, an interventional program could have that, right? It could have the benign pancreas guys. It could have the medical pancreatologist that's more focused on that and research related to that. The Barrett's esophageal person. I think it could have, an endoscopic oncologist, endobariatrics, like you mentioned. Those are all possibilities. Endohepatology, it's another one too.
It's amazing what, I mean, I trained 2009 to 10 in interventional. And when I finished, an interventionalist only did ERCP, EUS, and, interventional EUS was something that people kind of thought about, but we weren't doing. And all of a sudden, fast forward to 14 years later, and, all the crazy stuff people are doing, tunneling down the wall of the esophagus into the GE junction, or, whatever we want to talk about. It's crazy, and it's exciting to know what might happen the next 14, 15 years. That's going to be pretty cool. Okay, cool. So let me ask you also a little bit. I'm going to diverge a little bit off endoscopic oncology, and just kind of, one of the things that I like to advise people on this podcast is that everybody should kind of be joining their societies, ASGE, ACG. But you and Sharma, and as I mentioned, Dave and a bunch of other people started this, the FIGHT, Foundation for Interventional Therapeutic Endoscopy. I'm a member as well, involved with you there too. Kind of maybe for the people who aren't familiar that are listening to this podcast, number one, what is it, and why is it a good reason to join it, and kind of, what do you think about it?
Yeah, I mean, I'm going to be biased. I think it's a necessary program, right? And the reason why I think it's a necessary program is exactly what you mentioned. And you alluded to the fact that our field is growing rapidly, right? It's changing, and there's so much advancement in the field. We don't necessarily have a space that's 100% focused on that. I think ASG is extremely important, and I've been an active member. Like I said, I'm leading the SIG. I've been on a bunch of committees, and I really value it. I like ASG because it globally looks at endoscopy, which is a huge catchment that we need to focus on. And I think just as much endoscopy needs to be focused on the general work. In fact, 70, 80% of the work is general work, uppers and lowers, that are happening in either ASCs or in any health system across the country. And so we need that focus, and ASG supplies that. And then within that, there's interventional endoscopy. And so interventional endoscopy is changing rapidly. We require new devices. Oftentimes we're jerry-rigging devices to be able to perform things, right? I mean, we do it all the time. We're things that we know we want to accomplish a task, but we're using things that maybe are not the ideal tool. So a great example would be, we don't have steerable wires, but we're all doing access type procedures, right? And so how do we create a space where we can define and standardize the training, and that we can make sure that the field continues to advance with safety and quality, that when we have ideas that could translate potentially to new devices, we can partner with industry, but not necessarily be biased by industry. But we do need industry to be successful, because if you look at like interventional cardiology, it's a great example, orthopedics, they are so closely intertwined with industry, and industry can build new things like Watchman devices, right?
Yeah.
Valves that can be put in rather percutaneously. And those only happened because they created an environment that was so rich with it, capturing data, doing good trials, having good standards for training, that then they can be an investment from industry side on R&D, so they can develop these new devices. And then they also get codes, so then they get, some sustainability economically for the physicians around the devices. So the goal of FIGHT is to create that type of environment where we have standards of training, we have certification processes, we treat the field with the type of respect that we need, because all of us who have gone through the training understand that this is a complex field. We can hurt people. We want to help people, and it's innovating every day. And so that's what the real purpose of this is. We have a great 5-year vision that was laid out by David Lauren, who's the president of the Foundation for Interventional and Therapeutic Endoscopy. It's meant to be a foundation, so as it grows, it's going to give back. And it could give back to societies. It could give back to special interest groups like PCAN or ECAN, South Cancer Action Network, or ACS, because we do a lot of cancer-related work. But it's there really right now for free. So anybody who's a 4th-year trained interventional endoscopist could join FIGHT. I think the website is accessible to everyone at any time, so they can absolutely join.
Yeah. And I think it's important, to hammer home the point that my understanding, and I believe this is what you're saying as well, is it's not meant to replace ASGE or ACG or any of that. It's not supposed to be, it's there to, it's almost like a layer on top. It's another way to help out with the interventional endoscopy, but it'll support the other societies as needed as well. And it's not one of those situations where you're either this society or that society. You can be involved in both and be very active, and the society can benefit from you, and you can benefit from the society or the foundation.
100%. I think we're a unique field. We have ASLD, ACG, AGA, ASGE. So we have a whole lot of societies, and many of us are members of multiple of those. That's been out of conflict, right? There's plenty of room for everyone, and a lot of opportunity for everyone to be engaged. In fact, the more that we can get a diversification of people engaged in these different societies, the better for all the societies, the better for the field. And the more they collaborate, the more inclusive we can be. I think it's just creates more opportunities for people to be involved.
Yeah. So, we have so many societies. It's hard. It's expensive to join all of them. But I think the other thing too is, it's helpful. But one of the times where it's not is, the example is with the pancreatic cysts. ASGE has a certain set of guidelines, and then you have ACG with their guidelines, and they're not aligned, and they're kind of off on each other a little bit. And that's where it gets really complicated in our world. But all the societies have great things to offer. And I think, if someone's listening hasn't joined, or you're a fellow, definitely join those societies and get involved if you can, and it'll help yourself and everything else. All right, well, Neil, anything else you want to add? Or I know you're coming up to Phoenix in a couple of weeks to co-chair a course here. Do you want to talk about that, or any other things that you have going on that you might want to share with the listening audience?
Yeah, there's so many great courses right now, so I'd be remiss to not talk about maybe a couple of them. But, one that's coming up here in February, the weekend, I think it's February 24th, so be the 22nd, 23rd, is actually in Phoenix. Tuvik Kashami, who's the chair of medicine and interventional endoscopist there at City of Hope in your home city, he is one of the really the founder of this course. And the course is meant to integrate interventional endoscopists with other GI oncologists, surgeons, colorectal surgeons, medical oncologists, radiation oncologists, and so on. And so it's a multidisciplinary course. He's been very kind to invite me as course co-chair in all the years that it's been in inception. We've had 2 years so far, and it's the 3rd year. I highly recommend everyone to kind of at least consider going to the hybrid portion of it if you can't make it in person. But I think it's a great course. It's a beautiful place to visit. And then I think I have another course coming up right after that in April, which is the WISE course, which is Shyam Thakur's course, and Shalinder Singh's course. And this is their first year putting this on from West Virginia. That's in Pennsylvania, and it looks like an all-star lineup there as well. So I know there's a lot of courses, but I think this is a great time for people to collaborate and get to meet and know one another.
Yeah, and if nothing else, for the Phoenix course, it's not a bad place to be in this time of year. We don't have what's going on behind you, so. And when I saw it, I was like, "What is that? I'm not familiar with that." white substance falling from the sky. Yeah, but anyway, so okay. And then, I want to thank you for spending time. I know it's a busy time for you, and I know you're starting your job tomorrow officially, although you've been doing stuff for the last few weeks. But, congratulations on the change, and thank you for coming out and spending some time with me, and I really appreciate it. And then one other thing that I just always say at the end of every podcast is, for the listening audience, mental health amongst physicians is a huge topic. We are dealing with basically an epidemic of physician burnout and suicides. And if you're struggling, please reach out to somebody, either through social media. You can reach out to any of us, or reach out to your local 800 numbers and, just get some help if you're struggling. So with that, I want to thank you, Neil, and until next time.
Thank you so much for having